Morning. Thank you for this invitation to come to your conference. This is my first time in Salt Lake City, and absolutely startled by the mountains and the vista and the view. It's really a wonderful place to be. I'm jealous of all you folks. I'm from Chicago, and we don't have too many mountains in Chicago, but I certainly can appreciate what you folks see every morning. Today I'm going to be talking about epidemiology, case definitions, and diagnostic work. I've been doing work in this area for the last 10 to 12 years. I personally feel that there's no topic that's more important in chronic fatigue syndrome or fibromyalgia than basic case definition, basic diagnostic work, basic work on epidemiology. Chronic fatigue syndrome and these other mysterious illnesses, I think, are the great challenge for medicine for probably the next few decades. What I'm going to suggest today is that these particular methods are so critically important for both practitioners as well as scientists and also the patients in the field. How large or how small we sort of think of these particular illnesses, whether we think of them as lumpers or clumpers or all types of other different ways of thinking about them, has critical decisions and implications for both the allocation of resources as well as how research is done. So the foundations of this particular field really rest on how we decide who has this particular set of symptoms and who doesn't, how we basically make these discriminations. And over the next hour, I hope to provide some evidence and some suggestions of why these issues are so critical for the field and why, because of some confusion in some basic issues of science, we have some of the difficulties we have for understanding patients with these types of conditions. First thing, as the slide suggests, 25% of the population has fatigue at any one time. So fatigue is one of the more common complaints. Because 100% of people experience fatigue at some point during their life, everyone has kind of a reference point for what fatigue is and how it affects us. Because this experience of fatigue is so common, sometimes individuals think that what they have experienced as fatigue is similar to what patients with chronic fatigue syndrome or fibromyalgia are experiencing. And this makes it a real difficult time for the patients to understand other people's reaction to them or people around them to understand them. Because, again, fatigue is so well understood that everyone kind of walks around saying, well, okay, I have fatigue, I've experienced it, but I get on with my life. And then they look at patients with chronic fatigue syndrome and they say, how come that's not the same with yourself? So this issue of being such a common complaint is something that also makes it very difficult for people with chronic fatigue syndrome to really have people understand what it is they have. It also has incredible implications for, again, how we define who has it and who doesn't have this phenomenon of interest. Now, even though 25% at any one time might say that they experience fatigue, chronic fatigue, what's called 6 or more months of fatigue, is experienced by a much smaller percentage of the population, about 4%. About 1 out of 20 people will say that over the last 6 months they've experienced fatigue. Among this group, only about 1/10 of this group of 4% actually have what we think of as chronic fatigue syndrome. So again, it's a very small percentage of these. So the key question is this group with the diagnosis of chronic fatigue syndrome, 1/10 of this 4%, are they really different from this larger 4%, or are they similar? Now again, some individuals in science feel that there's really no differences and we should be just looking at those with chronic fatigue. Others feel that we should be looking at those people with particular syndrome pattern. So let me first talk about what that syndrome pattern is, at least as defined by the United States and the rest of the world at this point. Those criteria were defined in 1994. And the criteria involve, I'll go through them real quickly, an update on what had initially started in 1988, which was called the Holmes criteria. The Fukuda criteria, because he was the lead author of this paper, basically indicates these particular characteristics. Persistent or relapsing fatigue, 6 more months, that's again central. clinically evaluated, unexplained, persistent, or relapsing fatigue. And again, think about this. That is not new or definite onset. Well, this created all types of problems for people who are trying to decide whether you have it or don't have it. Because in the case definition, they never defined what new or definite onset was. What does it mean not to have lifetime? And this became a real problem for trying to decide what is lifetime versus not lifetime. So if a person was kind of a teenager and they got chronic fatigue syndrome and it never recovered, does that mean that they have had it lifetime or not lifetime? Very unclear. There's been a recent document by Bill Reeves and others, and I was one of the people on that paper that came out, that tries to kind of come up with criteria for some of these statements, and this is recently published. And right now, the way they refer to this particular criteria is if you can never have a time, if you can never remember a time that you felt well. Okay, so you never have a time, then that's really what we think of as lifetime. Okay, so that's the type question. But again, you see, you can come out with a phrase, but you've got to operationalize it. And that was the failure of the 94 case definition. They came out with criteria, but they didn't operationalize almost any of the criteria. And that led to people not being able to decide whether they had the symptom or not, they met the criteria or not. What does that ultimately lead to? Diagnostic unreliability. And then you have different patients and different samples that aren't the same. And then you have difficulties getting similar results, whether it's laboratory or psychological. Another criteria of this Fukuda definition is fatigue is not the result of ongoing exertion. Now, patient community kind of looked at that and they said, well, that's interesting because exertion makes them feel fatigued. So what does that mean? Again, it wasn't operationalized. What this really means, and now has been an effort to try to define it, is that if you have like 3 jobs and you're always working, and you basically are working from morning to night, which again is not uncommon in our society, and you're feeling fatigued because of that, and you cut back on some of those work activities, and then you feel fine, okay? Then that would suggest that it's really work-induced. People with chronic fatigue syndrome, even if they cut back, they might be able to not have fatigue, but they don't have stamina, they don't have the energy, and that's the key issue here. Fatigue is not substantially alleviated by rest. Another interesting symptom, again, the patients kind of said, what do you mean? If we rest, we basically feel fine, and we basically don't have that severe fatigue, or at least it gets moderated. So there was, again, a disconnect between a criteria in terms of stating it and not operationalizing it. What really it means is that the fatigue, even though it might get reduced at times for some people, and again, this becomes critical. For some, it seems to get reduced. Some it doesn't. We'll talk about that later. But just because fatigue might get reduced by rest, it doesn't mean it goes away completely, so that you still have the symptom pattern, so you still have the lack of physical sort of endurance or stamina. So you can't do many of the things that you used to be able to do. That's the key issue. Now, fatigue results in substantial reductions, previous levels of occupational, educational, social, personal activities. Again, what's interesting is they never, in the 94 case criteria, said what does it mean to have substantial reductions. You've got to operationalize that. And now we, in a paper that, again, Bill Reeves and some others have published, we're setting up some criteria for how to measure substantial. And there are some disability scales, SF-36, the MOS, that can allow us to begin to start defining what does it mean to be substantial. Now, in addition, the prior 88 criteria had 8 of 11 symptoms. Now you had to have what's called 4 of these other 8 symptoms. And these things include things like memory or concentration problems, and you'd have to have 4 out of these 8 symptoms that are on the slide. The difficulty here from some of the work that we've done in Chicago is that these symptoms are very common in the population. And when we give healthy, normal populations these symptoms, we find it's not infrequent for healthy people to say they've experienced these symptoms. The key difference is healthy, normal people, when they experience these symptoms, experience them at very low levels. And they experience them for short durations, and they seem to get better. People with chronic fatigue syndrome experience these symptoms with high intensity. I'll give you a quick way of thinking about this. If you asked fatigue for people who are chronically depressed, you'd find that about 100% say they're fatigued. You can't differentiate that occurrence of fatigue or not with people with chronic fatigue syndrome. However, if you ask the severity of the fatigue, what you would find is people who are depressed don't have fatigue as severe as people with chronic fatigue syndrome, and that would allow you to differentiate the two groups. So severity is critically important. We need to be moving from just the occurrence to severity if we're really going to be able to differentially separate people with chronic fatigue syndrome from potentially other conditions. Now, fibromyalgia is another of these somewhat mysterious or difficult to understand symptom complexes. By case definition, it's widespread pain that's been present for at least 3 months, pain in 11 of 18 tender point spots on digital palpation. And these are some of the spots where it would occur. Very interesting. Remember we talked about chronic fatigue being 4%? Well, it's about 4% with fibromyalgia. So 4% keeps coming up. Why 4%? 4% have chronic fatigue, 4% have chronic pain of the U.S. population. Very interesting. And look at MCS, multiple chemical sensitivity. It's chronic polysymptomatic condition due to low-level chemical exposure. What's the prevalence? Again, about 4%. Fascinating. Why is it 4% keep coming up with these different mysterious illnesses? Look at Gulf War syndrome. Again, if you look at the people coming back from that Gulf War, about 5% had chronic fatigue syndrome. So 4 to 5%, that's interesting. Gulf War syndrome is probably a little bit different from chronic fatigue syndrome. The Gulf War syndrome was primarily male. Chronic fatigue syndrome is primarily female. Also, the chronic fatigue syndrome, you have more of a sudden onset. With the Gulf War syndrome, it's usually more of a gradual. But still, this issue of why 4 to 5% of the population seems to be coming up, or people who go to a war seem to be coming back with what this thing of chronic fatigue. Very interesting from an epidemiological point of view. Let's go through history, and again, try to suggest why epidemiology and case definitions are so critically important. In the 1980s and early 1990s, patients were thought to have yuppie flu. There were few minority group members, mostly women, mostly well-educated. These studies were based on some case ascertainment methods, some of them done by the Centers for Disease Control, others done in Australia. Real briefly, the way they did these studies, they went to 4 cities in the United States. One of them was Atlanta, Wichita. And they asked the physicians in those areas to recommend patients that they might have that had chronic fatigue syndrome. Then they counted the patients and they tried to make estimates of prevalence based on that. Well, you could probably imagine some of the difficulties with that in the U.S. Healthcare system. Some individuals probably don't have physicians to be referred into this type catchment study. In addition, some physicians, particularly in the early 1990s and probably today, didn't believe chronic fatigue syndrome existed, so they weren't going to nominate patients. Well, that led to estimates of approximately 4 per 100,000. Okay? That would lead to about maybe 20,000 people with chronic fatigue syndrome in the United States. If there's very few people with a particular syndrome, like 20,000, it's considered a relatively rare disorder, you're not going to have a lot of public interest, or the agenda is not going to be high for resources for understanding this particular illness. And that's exactly what the problem was. If you have a belief system that this is a particularly rare disorder, then you have sometimes difficulties to break that belief system. And again, just to show you how science works, we sent the grant in from DePaul to kind of do a community-based study. And we said we want to bypass physician gatekeepers and just do a random sample. And from that random sample, try to estimate the prevalence of chronic fatigue syndrome. When we sent our grant application in, they basically said, well, if there's only 4 per 100,000 people with this syndrome, and you sample 30,000 people, you're not going to find anybody with CFS. So they refused to give us the money. So again, there was a battle that occurred for a period of time with the National Institute of Health until we eventually did, fortunately, get the funding for this particular study that I'll talk about. In any event, you can see these are prevalence rates of chronic fatigue syndrome. It's really incredible if you think about prevalence rates kind of ranging from 2 or 3 or 4 up to 2,500. Well, the reason these prevalence rates are so different is because you have different methods of basically trying to ascertain the sample of interest, and you also have different case definitions that are being used by different people. If that's the case, you can imagine what the scientific field is like. If you've got problems with case definition, problems with estimating prevalence, ultimately you have difficulties in having similar samples in different settings that you can make generalized statements about. Because if different samples have different characteristics of individuals, it's very hard to understand who it is we're studying. And even if you do find a particular homogeneous group, there's probably important subtypes that need to also be thought about, and we'll talk more about that too. To do good epidemiological research, one needs to have a multidisciplinary team of different individuals with different points of view. And I think that's what we try to put together in Chicago. Before one does work in this particular area, and what I'm going to do for the next half hour or so is just talk about this particular study that we did in Chicago and suggest that if one carefully defines the types of terms, defines the methods of which one goes about studying something, one can learn a tremendous amount just in one study about the characteristics of people with these types of mysterious illnesses, very difficult to understand conditions. First thing in our study, we validated our screening scale. We also got an instrument together. We gave it to 4 different groups, people with CFS, MS, lupus, and healthy controls. And we found that the instrument had good reliability and was able to differentiate these groups, at least to the extent of the CFS and the healthies. And when we couldn't differentiate some of them on symptoms, our physician referral was able to kind of make that last discrimination. So again, you're thinking about a 2-step process. One is you have thousands of people you have to screen, so you have to decide who among them might have the particular symptoms, and then the people that you identify with the symptoms, you then have to have a physician to kind of make the final diagnosis. We also did some testing with psychiatric instruments, and again, show you how controversial this whole field is. We gave a similar group of patients 2 psychiatric instruments, one called the DIS and one called the SCID. And this was, again, before we launched our full large-scale epidemiological project. And very interesting, we found that with one instrument, the DIS, the Diagnostic Interview Schedule, we had about 50% having a current Axis I psychiatric disorder. When we used another instrument, the SCID, Structured Clinical Interview, we got about half that number. Now again, if you use 2 different instruments and you get such strikingly different psychiatric comorbidity, that tells you something about the instruments that are being used. What's also interesting is that the entire field at that time was using the DIS. Now, the Diagnostic Interview Schedule, for those of you who haven't given it or aren't psychologists, is an instrument that can be given by lay people. You don't have to have a tremendous amount of training. But it's not developed for people with medically ill conditions. The SCID, on the other hand, has to be given by someone with at least a master's degree, has a lot more flexibility. Just to give you sort of a sense of why these instruments are so different, why they get such different outcomes, using the DIS, if you ask a patient for a particular symptom, and then you follow it up by saying, have you ever gone to a physician who has thought that it was due to life stress or more psychological variables, if the patient says yes, that any physician they'd ever seen with that symptom has that particular response, that the physician thought it was that more of a psychological issue, that symptom gets classified as a psychological condition. But you got to think about these patients. Patients might go to 15 or 20 healthcare providers. If only one of them basically said that they thought that it was that particular situation, they would get classified that symptom as a psychiatric disorder. And that's the bias that's in this particular instrument. I remember clearly presenting these results at a major CFS conference where most of the people in attendance were using the DIS. And again, just to kind of show you how sort of sometimes science moves so slowly, the people in the audience basically said, well, that's interesting, but we're not going to stop using the DIS because it's more convenient to use. And it really has taken probably almost about 8 years for at least a certain segment of the CFS community to start shifting to using a more appropriate psychiatric instrument. But we recommend strongly that with chronic fatigue syndrome patients that you use the SCID. We started the work in 1995, where we had a stratified random sample of about 30,000 people. We had a telephone survey that we had already validated, and we were able to complete interviews for about 18,000 people, so about 65% of the sample, which is pretty good for these types of surveys. And this was kind of some of the initial data that came out. And this is basically a fatigue score. This is called the Chalder scale, and this is the numbers. And fatigue score gets higher. That means more fatigue. And you can see that fatigue, as expected, is really a normally distributed symptom. And within the general population, you have some people with very high levels of fatigue, some people with very low, and the majority of people experience some fatigue. Again, nothing surprising, and that's what you would expect. You'd expect this with many different entities besides fatigue. And certainly, these are the group that we'd be most interested in studying. Also of interest is that females tended, in the general population, to have higher levels of fatigue than males. And again, we can think of a number of explanations for that. Certainly in our society, females tend to have sometimes dual careers where they have to have the family responsibilities and come home, have work responsibilities, and sometimes taking care of grandparents as well. So I think that the added stressors that are on females today could be accounting for that. There could be other biological reasons as well. But certainly it's not something that it would be unexpected. Now this was a little bit harder for us to understand when we came up with these scores. In the general population, we found that fatigue was actually higher among Latinos, African Americans, multiracials, and Native Americans. Now why does this become such an important finding? Almost everything we know about both fatigue and chronic fatigue syndrome is based on this group, white individuals. Almost all individuals that come into tertiary care clinics are this group here. But if these individuals are having more fatigue than this particular group, the question becomes, the people that we're studying, who are they? I mean, are they different? Are they fundamentally different? And what's important here is that there might be people in the general population who have certain characteristics of fatigue and maybe chronic fatigue syndrome who differ fundamentally from the individuals that we see who come into tertiary care clinics that get placed into the studies that we get research on, that we learn to know something about. So again, a very important issue. We'll talk more about that in a second. This is a finding, again, in the general population between four groups: African Americans, Caucasians, Latinos, Asian Americans. And as you can see, these are males in the darker color, females in the lighter color. For each of the ethnic groups, females tend to have higher levels of fatigue than males. Okay, that's not that unsurprising. The interesting thing from my point of view is that Latino group. For Latinos, the difference is significant, and it's stronger than any of the other ethnic groups. So for some reason, Latina women versus Latino men have the largest differences between fatigue in the general population. We've talked to a number of individuals about this finding, and it could very well be that women tend to take on, again, many more responsibilities in the Latina culture, and there could be other factors too. We've just actually looked at, among this Latina sample, the lower 50% in terms of socioeconomic status and the higher 50%, and we looked at, again, those who are older, those who are younger. And actually, this is the group that seems to have the most fatigue. Those who are the lower socioeconomic status, who have the fewer resources, as well as those who are older, maybe have more obligations and responsibilities. So certainly there are cultural, sociological factors that might be critically important as we try to understand fatigue. Another finding that we haven't published yet that I think is interesting is that we looked at, among the Latinos, those who spoke Spanish versus those who spoke English. And one of the reasons we were probably effective in reaching a number of these individuals is that we had individuals who could speak Spanish who were part of our interview group, as well as our group that went to them to bring them in for a medical examination. So we had two groups of Latinos, one who were Spanish-speaking, which means they were probably more connected with their roots, which is mostly Mexico, versus those who are English-speaking, who might have been more acculturated, okay? The English-speaking group generally were more educated. Generally, they had better jobs, better, you would think of, better, a number of different dimensions. The Spanish-speaking group were less educated, had worse jobs, and had, again, another of other kind of risk factors. So I just want to ask you, by kind of a raise of your hands, how many people think that the English-speaking Latinos actually had, I think we're kind of losing our, the mic kind of goes on and off. But you can all hear me back there, right? Can't you? Okay, good. Just interesting, kind of a show of hands. How many people think that the English-speaking individuals in our Latino group, actually that group had less fatigue because they had higher jobs, more education, and more of these other positive things? Just how many people would think they had less fatigue? Just raise your hands. Okay? How many people think the other group, the Spanish-speaking group, who had basically less education, less well-paying jobs, how many people think that that group was the ones that had more fatigue? Okay? Interesting. What we found was that the group that had basically the Spanish, oh, here we go again, all right? We're back online. Okay, the group that was Spanish-speaking, the group that had the more risk factors, actually had lower fatigue. Interesting. Again, so this is really a complicated issue of trying to understand fatigue in the general population. And I might say that as psychologists, we know a tremendous amount about anxiety. We know a tremendous amount about depression. But fatigue is one of those areas that we have not spent a lot of time studying, particularly in some of these ethnic issues. And it probably is unfortunate because fatigue is such a common and such a limiting type of phenomena in terms of people's experience. Well, in our general population, we found about 4% had 6 or more months of fatigue, 7% had 1 month of fatigue, and about 88% of the population didn't have what is called prolonged or chronic fatigue, when that was not unexpected. We also did a factor analysis of about 780 people with chronic fatigue, and what was interesting is 4 dimensions came up. And I just want to focus on these 2, physical exertion and cognitive functioning, because these are different than lack of energy. And I just want to make that point because we'll come back and look at that in a second. That if you have just a lack of energy, it might be very different from if you have physical exertion fatigue. Just because you have lack of energy and physical exertion fatigue, there might be fundamentally different processes in cognitive functioning. And these 2, the reason they become very important, we'll talk about this later, is a new case definition actually requires these 2 dimensions to have a diagnosis of CFS, whereas the Fukuda criteria, they're optional. They're only 2 of 8 categories, of which you need 4. So a person could, for example, not have these 2 dimensions and still be diagnosed with chronic fatigue syndrome. And that's one of the diagnostic problems, because you don't have some of the specificity that's needed for cardinal symptoms of chronic fatigue syndrome with our current case definition. Okay, the second step was we took about 227 people and 74 controls, and they underwent psychiatric evaluations. And we also found some interesting in terms of current 1-axis and lifetime axis. Clearly, people with chronic fatigue syndrome have a higher prevalence of psychiatric comorbidity. That's something that has been said by many people. They include things like mood disorders. This is the chronic fatigue group. Healthy controls, you can see the contrast. So for mood disorders, for anxiety disorders, and post-traumatic stress, clearly individuals with chronic fatigue have a higher estimates of these types of conditions. In addition, we basically worked them up medically to rule out other medical conditions. And this is kind of interesting. We looked at those people who had a psychiatric diagnosis based on the SCID. And then we looked in the medical records to see if their physicians had been able to diagnose them with a psychiatric diagnosis. And we found that in about half the cases, the physicians were basically either not identifying people who had a psychiatric disorder, or sometimes they were diagnosing people with a psychiatric disorder that didn't have it. So what this thing suggested to us is that it's very important to work in a multidisciplinary setting, that if you're not sure of a person's Axis I psychiatric diagnosis, you really should have some type of mental health professional be doing a workup to confirm whether they have a diagnosis or not. The reason is because some of these psychiatric conditions are treatable. And some of them, if you treat them, you can make substantial improvements in the patient's functioning. Okay, we did a very fancy statistical technique. Now, I look at this, and this is for a scientist, researcher, this is kind of like art. I look at this, and it kind of makes tremendous sense to me, and I kind of say, this is like a Rembrandt for me. So this is what scientists look for. They kind of say, can I find something new that sort of people haven't found before? That's what drives us to do this type of research. And for me, this says a tremendous amount about the field. So let me try to tell you kind of why it jumps out at me, and it might not be as obvious. What is fatigue and rest? These are kind of 4 groups of patients, okay? 4 different clusters of patients with 6 or more months of fatigue. Almost all the patients with chronic fatigue syndrome were in these 2 clusters. What does that mean? That means this is lack of energy. Lack of energy is pretty high for all 3 groups. Just because you have lack of energy and you have fatigue is not the differentiator between those who have chronic fatigue syndrome or not. They all have fatigue. What's critical is to look beyond that. These are the things that are, I think, critically important. But let's just look at this one for a second. This means fatigue and rest. This particular group, if they rested, their fatigue did not get better. They did not feel any better, okay? They still had all these symptoms. This group, if they rested, their fatigue got better. What that suggests to me is we're talking about 2 fundamentally different groups of patients. Some patients seem to be able to feel a little bit better with resting, taking it easy. Other patients, their high levels of fatigue are up there regardless of what they do. That probably has critical importance for our case definition. So, cognitive problems, physical exertion problems, again, take a look at these numbers and then take a look at this in this group. You see, the physical exertion, the problems of people with just fatigue of 6 months versus these groups here is remarkably different. The group with chronic fatigue syndrome, when they involved in physical activities, they feel worse. They have basically this called exertion-related fatigue, post-exertional malaise. You don't get that as much with people with just chronic fatigue. And that's why this particular symptom is so critical. And yet, if it's optional in the case definition, and if memory and concentration problems is optional in the case definition, you can have individuals who are getting the Fukuda case definition who don't have the 2 cardinal symptoms of chronic fatigue syndrome. That's the problem with the current case definition. Okay, back to some of our data. This is age groups, and as you can see, the group that was most prevalent age was around 40 to 49, which was something we expected. This was, again, something unexpected. Latinos and others had the highest rates of chronic fatigue syndrome, and African Americans had rates of chronic fatigue syndrome as high as whites. No one had ever found that before. And again, the interesting thing from our point of view is that about 90% of the people we had worked up had never been diagnosed with chronic fatigue syndrome. So here we have a whole group of people in the community who are sick with these classic symptoms who have never been diagnosed and probably not getting appropriate treatment either. And most importantly, if more than half of individuals with chronic fatigue syndrome are minorities, and yet in our research reports we know nothing about minorities with chronic fatigue syndrome, again, that becomes a real problem. Everything that's published and all the data about what we know about chronic fatigue syndrome might not be representative of the population of people that have this particular syndrome. Skilled workers seem to have the highest rates. Very interesting. The old yuppie flu, people with the highest socioeconomic status did not have higher rates of chronic fatigue syndrome. Again, that myth did not seem to be accurate either. Females having higher rates than males. Again, that had been found by a number of other more tertiary care clinics. What's the prevalence of CFS compared to other disorders? If you look at women with CFS in our Chicago study, it's about 522 per 100,000. Take a look at these other conditions. What this suggests is that CFS, particularly among women, is a high prevalence symptom, and the resources allocated to these particular conditions is minuscule compared to these particular conditions. There's less than probably $10 to $15 million a year being allocated to any type of research or services for people with chronic fatigue syndrome. That's not the case with these other conditions. We also found that the majority of CFS respondents did not have a history of abuse. Certainly these percentages are higher than in the normal population, but one can't just assume that abuse is what's causing these particular symptoms. Certainly abuse could be a risk factor. Abuse involving that, as well as other types of risk factors, could ultimately have a person succumb to this disorder. What's also interesting is when we looked at the family histories of people with chronic fatigue syndrome versus our control group, we found that particularly something like diabetes was much higher in the families of chronic fatigue syndrome, suggesting that there might be something genetic. There might be some types of even maybe autoimmune diseases that are within these particular families or other types of endocrine problems that might be making these individuals possibly more at risk for other types of things that end up with person having CFS. And there's some very interesting work that's now currently going on genetics with chronic fatigue syndrome that I think ultimately is going to be extremely helpful to us if we can diagnose and get the right case definition to specify who it is we're talking about, and within those case definitions, really try to find out different types of individuals. As we suggested before, some individuals with CFS possibly have very different types of post-exertional malaise, particularly in reference to rest. Seasonal variation, another study we did was we said, okay, is it possible that people with CFS might get more onset during January or during winter months? And that's something we did find, suggesting that maybe there could be flus. Certainly, rapid onset is something that many patients suggest occurs with their symptoms, and this was some confirmation of that. In terms of gender differences, women with CFS were less likely to be working full-time, reported greater perceived stress, were more likely to turn to religion, had more severe muscle pain, more impairment of work activities, more functional impairment. In terms of ethnicity, minorities with CFS had poorer general health. Very interesting. We found, particularly among our Latino samples, that they seem to use more denial. And also some of our African American samples seeming to turn more to religion as a coping mechanism, and somewhat behavioral disengagement. Also in terms of symptoms, sore throats, post-exertional malaise, headaches, unrefreshing sleep, more symptoms. In terms of work status, working individuals reported, as you probably imagine, better functioning, and that's probably why they were able to work, because their symptoms were less severe. Mode of onset, those who had a sudden onset had more severe sore throats, more severe post-exertional malaise, suggesting maybe some connection with an infectious onset precipitator. In terms of stressful life events, those who reported a stressful event occurring at the time of onset had lower levels of vitality, poor emotional role functioning, those without a stressful event. So certainly there could be psychological variables that could be influencing the onset of this particular syndrome as well. Duration of illness, those who had shorter duration of illness had better general health but more severe lymph node pain. Again, another issue of case subtyping, we looked at high versus low symptoms, and individuals who had high numbers of symptoms tended to be female, tended to be older, less likely to be working full-time, more likely to be unemployed, and on disability. So it's very possible that among the patients that you see, some quick diagnostic for you is to really look at the number of critical symptoms they have. Those patients who have more symptoms are probably going to have a different type of this illness than those patients with less symptoms. And there might really be kind of almost stages of CFS. We have an instrument that we worked on with Pat Fennell, that looks at the stages, so that during the first year it almost seems like people feel completely out of control, looking for a desperate search for relief of symptoms and cure. And during the second and third stages, people seem to get a little bit more control over symptoms, have a little better appreciation, and during the fourth stage, a person possibly has more of a better sense of control and feeling good about oneself as opposed to being kind of really at the mercy of their symptoms. So certainly the phase of an illness might be critically different, and the biology of individuals in these different phases might be very different. A person who comes to you in the first year of crisis might be a very different pathophysiology than a person 6 or 7 years down the line who has learned to, for example, live within their envelope, minimize symptoms, and have a better quality of life than they had during that first year. Rates of coexisting disorders. Among our group, only 16% met criteria for fibromyalgia, whereas in the literature, rates are probably closer to 50 to 70%. Again, why this becomes so important, again, it's like the clumpers, bringing everything together. This is all just one thing, lumpers, separators, splitters, have all these different labels out in the field. Well, I mean, if in our clinic-based treatments, 70% of individuals have comorbidities, the fibromyalgia and chronic fatigue syndrome, then we say to ourselves, well, maybe it's really one thing. But that's why a population-based sample is so important, because when you look in the population and you look for these symptoms, what you find is people with CFS generally don't have fibromyalgia in a population-based sample. It's not the same in a clinic-based sample. So I had an interesting, just two experiences over the last day. One, in a recent issue of the Journal of Chronic Fatigue Syndrome, some of our colleagues from Belgium were kind of saying, well, gee, these really are very similar symptoms. If you go to a rheumatologist, you'll get called fibromyalgia. If you go to an internist, you'll call it chronic fatigue syndrome. And we can't seem to see many differences between these two patient groups. And yet, when I talked to Stacy Stevens yesterday, and you'll hear more from her today, she said, fundamentally different experiences when she works with these patients. The people with fibromyalgia really do pretty well on these aerobic exercise regimes. The people with chronic fatigue syndrome don't. So again, critically important to make these diagnostic decisions about what symptoms relate to which of these particular classifications and which ones don't. Are they separate? Are they different? Fundamentally important for not only the science of the field, but also in terms of clinical interventions that many of us are involved in. Those with comorbid fibromyalgia did have more of these types of symptoms. So people who have two of these conditions tend to be sicker. If you have multiple chemical sensitivities, on top of that, you're going to even have more symptoms. So you add on these conditions, you have more different symptoms. Psychiatric comorbidity, approximately half of the individuals with CFS had the presence of a premorbid psychiatric diagnosis. But what's important is that half of them didn't. So you can't just say it's a psychiatric condition, because at least half of the people had no prehistory of any psychiatric condition. But of course, individuals who have a current psychiatric diagnosis have overall more fatigue and more impaired emotional role functioning. And that's why it's very important to have sometimes these multidisciplinary teams, because you might be treating a particular person's physical complaints. You might have a psychologist, a social worker, or other healthcare worker working on some of the psychological issues. We also looked at CFS pediatrics and in our sample, and what we found was none in our 5 to 12-year category, and that's a very controversial area, whether CFS can occur among pre-teenagers. But among our adolescent sample, 13 to 17, we did have rates of 181 per 100,000. Remember, the rates for adults is about 420. So rates among adolescents is about half that. So really, it's very different in adolescents versus adults in terms of prevalence. In addition, prognosis seems to be quite different. CFS in adolescents seems to be a much more positive, hopeful prognosis than it is among adults. So now I'd like to shift to this new case definition that I've been alluding to, and it's called the Canadian case definition, and it came out about a year ago. We've just used our epidemiology to take a look at 3 different case definitions. And again, Now, this is why I keep sort of saying it's so important, sort of the framework that we place on the work that we do can have remarkably different results. Up on the board, on the slide, this is the same group of patients, from our prevalence study that we looked at from 3 different lenses. We looked at the 1988 case definition, which, remember, I kind of said had 8 out of 11 symptoms, so it's a little bit more symptoms, probably kind of a more disabled, a sicker particular group. This is the Fukuda case definition that came in 94, which was looser. All you needed was 4 out of the 8 symptoms. And this is the Canadian group, which is somewhere in between. This is the number of patients that we were able to diagnose from kind of a large catchment study. So let's kind of look at what some of the findings indicated. When we looked at the 1988 versus the 1994 criteria, those who met the 88 criteria had significantly higher rates of sore throats and lymph node pain. On the medical outcomes survey, those that met the 88 criteria had poor health functioning. So think about it. You've got some investigators who are using the 88 criteria, some investigators using the 94 criteria. They're not getting exactly the same patients, and then they're making statements about saying, why do we not have generality among our samples? Well, part of it is they're using different case definitions. That's a problem for the field. Let's go over the Canadian criteria, because I think what the Canadian specifies is some of the solutions to the Fukuda difficulties that we've been talking about. So let's just go through them point by point, and what I would really encourage you all to do is to be thinking about using the Fukuda criteria and possibly also using the Canadian case definition when you're diagnosing your patients. So let's go through them. First, the illness persists for at least 6 months. There's a marked degree of the new onset of unexplained, persistent physical or mental fatigue that substantially reduces activity level. Okay, this is pretty constant across the 3 case definitions. But here's the first one that's different. This is required. Post-exertional malaise. That has to be in your patients. It doesn't have to be there in the other case definitions, okay? And that is what we think is one of the classic features of chronic fatigue syndrome. Another part of the Canadian case definition is there needs to be unrefreshing sleep or significant degree of pain, but it doesn't have to be. If you have not these 2 symptoms, but you have the classic onset of probably an infectious illness, they're not required because some patients don't have these symptoms. In addition, there needs to be neurocognitive manifestations. Remember I kind of mentioned confusion, impairment of concentration. You know, when you talk to patients with CFS and you say, what's your worst feature, symptoms, usually they'll say it's the cognitive problems. You know, they wake up, they sometimes can't find their keys. They get in the car, they go somewhere, and they forget where they're going. You know, when you're in a work setting and you can't remember things and you have short-term concentration, it makes it very difficult to hold down a job. So if this is one of the critical symptoms, then why wouldn't you want it in your case definition as required rather than optional? And that's what it is. In the Canadian case definition, it's required. In addition, there needs to be 2 of the following categories. And these are, again, autonomic manifestations, neuroendocrine, and immune manifestations. So let's compare the 99 criteria to the Canadian criteria. And let's say